Osirex. So there is a technical issue on Mac. In any case, let's start the viva.
Okay.
Just 1 second. Give me a moment.
Yeah, sure.
Now, okay, so this is your first case. Let me give you the history. 56-year-old abdominal pain, chronic abdominal pain. Mental health issues are there. She is reported to A&E. Over to you.
I'm presented with a frontal radiograph of the abdomen of a skeletally mature patient presented with the chronic abdominal pain. You can see there is a normal distribution of gas within the small and large bowel loops. I can see surgical clips seen on the left side of the pelvis. You're noting there's some surgical procedure done on the left side. You can see also there is dynamic hip screw prosthesis on the left hip. And air under both cobulas of the diaphragm. So I request to see both cobulas of the diaphragm in another projection to check if there is any pneumoperitoneum. And I'm checking also if there is any radio-opaque densities within the abdomen. I can see some phleboli or some calcific densities seen projecting at the right lateral aspect or right aspect of the lower abdomen and pelvis. It looks like it's in the skin. I'm checking the bones now. The pedicles looks normal. The sacrum and both iliac bones looks normal as well. And also in my routine practice, I would check for any hernial abnormality seen on the hernial orifice and lower pelvis for any hernial orifice. I can see also there are some lucency within the projecting over the right iliac bone. And the bones looks normal as well. There is no osseous destructive lesion. I would like to review the old study of this patient if there is any, to check if there is regarding the surgical procedure on the left side, if there is a mass removed or an abscess or drained or anything on the left side as well.
Right. So if you can review, is there anything else on this X-ray? If you can review, particularly, it's always a foreign body.
I'm checking down there.
The patient has got mental health issues.
Yes.
And there is some history that she
actually this radio-opaque density on the left side, maybe also I would like to zoom it in a little bit to check if there is, this could represent any foreign bodies.
Which side are we talking about? Left side of the patient?
Yeah, left side of the pelvis, yeah.
Left side of the pelvis. So this is the right side of the pelvis. This is the left side.
Yeah. The dense clips or dense foreign body radio-opaque shadow presented on the opposite the left iliac spine.
Happy, or should I zoom it?
It's low. It's opposite the acetabulum, left acetabulum, opposite the left acetabulum.
Happy?
Yeah. It's opposite the left acetabulum. There are two densities projecting over each other on the left side.
Don't worry about this.
Okay.
That was on the clothes.
And there is also translucent area in the center of the bell on the centered on the sacrum. I don't know if this could represent abnormal lucency or within the rectosigmoid bowel. Otherwise, I cannot see any radio-opaque shadow or any abnormal densities within this abdominal film.
So I'm giving you a zoom up view.
Okay, so these are fecal matter, I think, on the left side. And beside it, there is abnormal densities as well, and projecting on the left side, paraspinal region. I'm not quite sure if this is representing foreign body or something in the stomach or bezoar or something like that. Could be.
You mean to say in this area where
Yes, yes.
So I'm not worried about that.
Okay. So I cannot see any abnormal density regarding the foreign bodies in this patient.
Okay, let me give you a close-up. Anything else?
Calcification, nothing here.
Okay, what is this where I'm pointing out?
Oh, this is a radio. This is, yeah, it looks like a foreign body. It's linear and it has the spade like, looks like a spoon, a plastic spoon. Or yeah, could be a plastic spoon, or it is a plastic spoon actually.
Right. So what will you do to confirm this?
Yeah, so CT, I will project to the CT scan for this patient to check if there is, to confirm the position of this lesion, of this foreign body. It's either in the small or large bowel.
Right. Over to you. You can ask for the mouse.
Yes, sure.
Just 1 second, please.
Yes. Shall I request it now?
There is a issue. Just 1 second. Now, yeah, now you are approved. So the mouse is with you.
Yeah, I'm trying to.
So if you are unable to, you can scroll from the top bar also. You can hold and scroll.
It's not moving. Let me request again. I think it's not
Yeah,
active.
maybe request again, please.
Yes, sure. Yeah.
Approved.
Yeah, now it's moving. Yeah. So I'm presented with a CT scan of the same patient in the portovenous phase. I'm scrolling down the upper abdomen. Some diverticular disease of the transverse colon without complications. Some dilated renal pelvises bilaterally, and this is the radio-opaque shadow, that's faint radio-opaque shadow that's seen on the plain X-ray before. And it's in the jejunal bowel loops. And it's actually in the, yeah, it's in the jejunal bowel loop. I will check also for the, I will check the coronal view as well to.
Just 1 second, I'll give you the coronal. Give me the, you don't move the mouse, please.
Yeah, sure.
The coronal is with you.
Yes. Back again to the colon and small bowel, so nothing in the descending. Yeah, this is, it's a toothbrush. I think it's a toothbrush. Yeah, it's a toothbrush in projecting within the ileal bowel loops. Is this the same patient? I mean,
yeah, this is the same patient.
It looks like something. Yeah, it's a toothbrush actually. It's a portable toothbrush within the ileal bowel loops.
That's fine. So
Yeah.
is it doing something?
Yeah, because the patient has some psychological trouble, so I believe it can happen with these patients to swallow and these kinds of things. Yeah.
What I meant was, is it causing some obstruction? Anything
No,
else?
there is no obstruction.
Anything
No.
else you will like to tell the clinicians?
Yeah, there is no pneumoperitoneum, and there is no also ischemia on the bowel. I can see there is no edema, no proximal small bowel obstruction, or no mechanical small bowel obstruction seen.
Thank you.
Uh,
Thank you. That's it.
there is no perforation as well. Yeah.
Yeah, that's fine. There is a bit of technical issue at my end, and some of the other, I want to show you a PowerPoint, which I will have to use another device for that. So in this case, the PowerPoint was not important, but I'm just testing myself because otherwise the system will not work. So now this is case one. This is simple. It is a foreign body, small bowel, and it's a toothbrush. What is this type of a case? This type of a case in FRCR, however, there are various types of cases, and this is what we call an observation film. Subtle finding, unusual finding. Usually, once you pick it up, in this particular case, we went to actually a CT scan to confirm it. But many a times, observation films are easy, quick films. Once you pick it up, then the examiner might go to the next one. For example, you see a looser zone on a chest X-ray in the rib. That is another observation film. So just wanted to show you a simple, many a times observation films are warm-up films uh, where they show it just to highlight, just to start the YY, simple as that, nothing more than that. Okay. Sorry, it's a bad beginning at my end because there are some technical issues. Now, candidate one, are you with me?
Yes, sir. I'm here.
So this is a 53-year-old patient, known breast cancer, and they want to, the patient has got headache. They want to rule out metastasis. This is the clinical. Over to you.
Okay. I'm requesting the remote control. Yeah.
Approved.
I'm presented with an axial T1 weighted image of a female patient with a history of breast cancer and headache. I'm scrolling down the image now. Yeah. So there is no, in this axial flare sequence, sorry, it's a flare sequence. I cannot see any abnormal signal intensity within the both cerebral and cerebellar hemispheres. I'm scrolling, sorry for the lagging, because scrolling is very small. And in the both orbits as well, there is nothing in the orbits. Optical. Scrolling down. There is, in the base of the skull, I cannot see any abnormality. I'm checking the vessels now and the dural sinuses for any abnormal high signal intensity. So it's not scrolling now, stops.
Just 1 second, please.
Yes.
Ask for the mouse once again. Right. So I have now given you a T2 weighted sequence. Over to you.
Okay. So scrolling down the base of the brain, there is abnormal signal intensity seen within the left orbit, as well as there is increased thickness of both lateral and medial recti on the orbit as well, with high signal intensity, abnormal high signal intensity within the left retroorbital fat. I would like to confirm that on T2 stir weighted images or coronal images, and also I'm checking the cavernous sinus posteriorly and along the apex of the left orbit. Internal carotid arteries are with normal signal void, and there are partial empty cella. The vessels looks normal, middle cerebral looks normal here. I'm scrolling back to the top. No abnormal signal within the central semi-oval and the ventricular system are within average. In my routine practice, I will look for the coronal T2 and the stirred coronal T2 as well to delineate more the optic nerves and the
Leave the mouse, please. Leave the mouse for me. Don't move the mouse. I've given you a post-contrast scan.
Yeah. So in the post-contrast scan, there is abnormal significant enhancement of the more or the extraocular muscles with increased signal intensity. And
are you scrolling? You can scroll.
Yeah, I'm trying to scroll, but yeah, it works now. Okay, and the muscles are significantly thickened, edematous, with we're compressing the optic nerve in the middle, and with scanty, and there is abnormal signal intensity within the retroorbital fat as well. So in the context of the breast cancer, this could represent a type of metastatic disease to the orbit, intraconal metastasis, but it's unlikely because of the diffuse pattern of the involvement. Secondly, it could representing a type of myocytic pseudo tumor or myocytic IgG orbital inflammatory process. And also, I would like to check the cavernous sinus still and the superior ophthalmic vein to check if there is any thrombosis within the vein itself.
Okay, leave the mouse for me, please.
Yes.
You can see the cavernous sinus. I am scrolling for you.
Yeah, I can see the cavernous sinus looks normal. It's normally enhanced with no
Now,
with no
why did you
swelling.
say, why did you say that metastases are unlikely?
Because of the myocytic involvement, the diffuse pattern, it's more likely to be inflammatory rather than, but it's a possibility, of course, because there is also involvement of the lacrimal gland and also preceptal involvement and skin involvement on the lateral cancers as well.
Okay,
So
thank you.
it's a possibility as
Thank
well,
you.
yeah.
Thank you. I just realized that because of the technical issues at my end, I forgot to actually give you a feedback on the films, the previous films. So I
Yes, sure.
just described it on the PowerPoint. So for the audience also, I think that is needed. This is a case of a foreign body in the jejunum, which is a spoon. So please remember that psychiatric patients, things like that, and these patients will usually come back to you. Every year they will have. I've got a scan. I've got a patient with a toothbrush in the duodenum also. So they can eat things which normal people cannot. And so it was an observation film. If you see, it is there. It is there. It's a definite finding. The only thing is that somebody has to point it out. So this will happen, and then you look carefully, and it was there. Now, once you went to the CT scan, so you did well where you described it. The only thing is that you asked for a coronal, which was very good. So that was fine. But you did mention, I had to ask you the pertinent negatives. For example, there is no perforation, no signs of perforation means no pneumoperitoneum. But during your scrolling, you had not seen that. So please remember,
Yes.
you mentioned it when I sort of prompted you. Number one. Number two, obstruction, etc. So pertinent negatives quickly, you should have mentioned those also. And for pneumoperitoneum, of course, you need a different window. So that was critical. Now, as far as the current case is concerned, let me go back to my PowerPoint and case 2. So this was orbital metastasis, breast left. Now, I will give you the feedback on the findings after the PowerPoint. There is a bit of satisfaction of search, robust viewing protocol. You did well because you picked it up. And many people do not. So I'll come back to that point. Now, a differential diagnosis of orbital masses in the last edition, the sixth edition of Chapman, it was on one, differential 11.1. It gives you a global view, which makes it very interesting because global view tells you that lesions can be within the globe, lesions can be intraconal, then conal lesion means the cone, as in the muscles, extra conal lesions. And something which I have added here that add a few things which can happen everywhere. So things like pseudotumor, as in IgG4 related disease, or lymphoproliferative disorder. In head and neck, use this word lymphoproliferative, which is a whole spectrum. lymphoma, and it can be benign also. And then sarcoidosis, practically, and metastasis, you can add in any of these differential. That's a take-home point. In the current Chapman, which is the latest seventh edition, uh, we have divided them into multiple segments: orbit, globe, and so look at this: lymphoproliferative lesion, ocular metastasis from lung or breast, rare, maybe multiple or bilateral. I always say that one line in Chapman at times will save the exam for you or the Viva question. So everything has to be read with a lot of concentration. So it can happen even in globe, right? It can happen, so metastasis can go anywhere. They have not mentioned it here, but they can, of course, ultimately go into or surround the optic nerve. They can, so the intraconal fat, uh, and then the conal, as in metastasis. You see, this is our case. Conal metastasis, most commonly from breast, lung, melanoma, non-specific, usually in the non-specific mass. So there is going to be no pattern. It's an infiltrative lesion and extraconal. So in our case, that was also involved. What we call the lacrimal was also involved. So let's go back to the case. You did very well. And basically, I showed you a flare. Now, interestingly, on the flare, you were looking at the orbit, and at this point, you pointed out, actually, I love that you were looking at the orbit. You mentioned orbit, but you did not pick it up. You see this? And on T2, you picked it up
Yes.
immediately.
Yes. Yes.
So this is the human element. In the main exam, the examiner is going to continue with the flare. They will continue. And now you agree that it's you see, look at this lateral rectus. This is the lateral rectus. It is thick. Look at the fat. And now even, you agree that there is a bit of asymmetry. And you go one scan and look at the fat. Fat is also involved. So something is happening. So this is very interesting, the human element, that you were looking at it, you mentioned it, you did not pick it up. And on the T2, you picked it up immediately because it was more evident. So this was also a satisfaction of search indirectly. You see this? You picked it up immediately. But the role of contrast is critical. I don't mind if you ask for other sequences, but ultimately the diagnosis has to be made with contrast, fat saturated contrast. So that was it. Otherwise, you did well. And do you agree that on flare, what happened? Candidate, I'm asking you.
Yeah. It's there in flare, but it's very subtle, so I didn't see it.
Right.
Yeah.
So I warn you that in exam it happens, and the examiner will struck, and it has happened with many candidates, many of my students in the past. On a T2 weighted, I remember uh, paracranial meningioma on a T2 weighted with, and the examiner did not change the film, and the candidate gave me a feedback that she lost a lot of time on it. Ultimately, she passed. But having said that, so they will just, they can hang on there. So that was the point. And this is a classical exam where the eyes are not seeing what your mind is, going through because of the stress of the exam. So otherwise, you did very well. Your pertinent negatives, I loved them because you were asking for cavernous sinus and internal carotid artery, etc. So that was very well done. Good. So next case, I will. So this patient is a 62-year-old backache, left-sided acute sciatica. Left-sided acute sciatica. classical case which you see in your day-to-day practice.
Okay, I'm requesting the remote control.
Yeah.
I'm presented with a T2 sagittal scan of spiritual mature patient with sciatica. I can see the opposite, the L4 segment, there is abnormal. I'm trying to scroll down. Yeah. Yeah. There is abnormal intermediate signal intensity lesion projecting at the posterior aspect of the L4 level at the anterior epidural space. The disc, the L4, L3, L4 disc is dehydrated or degenerative a little bit. There is no connection with the parent disc at this point. I'm trying to scroll down the images to see in the parasagittal position. Yeah, so the fat in the keyhole here looks obliterated on the L3, L4, and L4, L5. And in the other direction, there is nothing, no abnormality. So the cord looks terminating on the level of L1, and the coda equina roots are looking normal. There is no prevertebral soft tissue seen at this level. In my routine practice, I will ask for the axial T2 scan, same patient.
I'm going to give you the T2. Just hold on, please. Over to you, please.
So in the corresponding level, I'm scrolling down.
You are at L4 level. Let me guide you. You are at L4.
Yeah, so there is abnormal. The same lesion looks in continuous with the left neural foramen with iso intensity to intermediate signal intensity seen at the anterior epidural space or extradural space, compressing the dural sac posteriorly, and the signal intensity is intermediate in the T2. I'll check also in the T1.
Just 1 second, please. Just 1 second. I'm giving you a T1 and then I'll give you the T2 axial once again. You can scroll through this T1.
So in the T1, it's ISO, also of low signal intensity.
Where is it?
It's extending along the foramen as well, the neural foramen here.
Right. So I'm going to give you the T2 once again. Just hold on, please. Over to you. You are at L5 right now.
Okay, I'm going up.
Now you are at L4. L4 is coming into you.
Yeah. So this is a dumbbell-shaped lesion involving the neural foramen at the L4, L5 level. And
where is the neural foramen?
It's down there. It's here, and it's extended.
So you are at, right now, you are at, I'm guiding you because I'm not showing you the, the sagittal. So this is L4, L5 neural foramen.
Yes.
So now tell me the anatomy.
This is the neural foramen of L5, compressing the L5 nerve root on the left side.
What is compressing? You mean to say the lesion is here?
The lesion extending along the nerve root on the left side, and obliterating the keyhole surrounding the nerve root in the coronal imaging.
Mm-hmm.
I would like to look for the T1 post contrast.
So the lesion did not enhance on post contrast.
So this might represent a sequestrated disc from the L4, L5, and compressing the left exit nerve root on the L4, L5 level. Second possibility could represent it's less likely, but I would like to confirm on the coronals. as well if it's extending along the nerve fiber to exclude neurofibromas.
I told you it did not enhance.
Okay, I'm scrolling down here.
Okay, just 1 second. Let me ask you a question. So
Yeah.
I'm going to scroll for you.
Yes.
Now, right now, we are at L4, L5 disk. We are not interested here, right? We are going up. Now I am going to the body of L4. This is L4, right?
Yes.
Now, what is here and what is here versus what is here?
No, I cannot see your arrows here.
You cannot see my arrow?
Yeah.
Actually, I've got two mobiles going, two devices, and I can see my own arrow. I can see it. You cannot see it now?
No, I'm pointing to this area here. You can see my arrows here?
Yeah. So this, where you are pointing, what is this?
I believe it's a sequestrated disk.
Which level are you at this point?
This one opposite L4, L5.
So which nerve root is compressed?
It's L4 nerve root.
L4 nerve root.
Yeah.
Okay, thank you. I'm going to take over. Now you did very well. This is a sequestrated disc compressing the left-sided L4 nerve root. It is in the lateral recess. And which level it is? It is at the level of the pedicle. So I just want to go through a bit of more about the fine touch of disc lesions. Now, please remember that in your protocol, it is a key when the examiners will usually give you a sagittal, and one of the thing is that you have to see the keyhole. So this is how it is. And the candidate did very well, mentioned the keyholes and immediately picked up the findings. So that was very well done. Now, the main concept to remember is that this is the pedicle. This is the pedicle level. This is the disc level. This is the pedicle level. This is the inferior to the pedicle. So if this is L5, then the nerve root will pass below the pedicle. It will pass below the pedicle. So this is L4, and the nerve root, L4 nerve root will pass below the pedicle. Now, the nomenclature and classification of lumbar disc pathology, there is too much controversy because various people use various kinds of nomenclature. I recommend you that initially published 2001, 2003, then nomenclature and classification of lumbar disc pathology in AJNR and other journals. And the review was published in 2014 in again in many of the journals. It is endorsed by many bodies. So I encourage you that if you are using the same terminology, you should also talk to your spinal surgeons or the orthopedic surgeons, and whatever you say and they say, you should be on the same page. So it's important. Otherwise, there is so much, terminology-wise, there is a lot of confusion. So this is from the original article 2001, 2003. What I want to point out here is that this is the vertebral body. From here to here is the pedicle. Superior to the pedicle is the suprapedicular level, and then is the infrapedicular level. Another thing which I want to point out is that this is the pedicle, this is the pedicle. This structure here is the what we call let me go to a laser pointer. This structure here is the lateral recess, lateral recess. and the nerve root will be passing in this lateral recess. And in our case, the sequestrated disc was actually obliterating the lateral recess. And then it will pass below and come out. So the concept of lateral recess is also important. I don't want to go into the definitions of protrusion and extrusion, but radiology assistant from the same reference, which I have showed you, 2014 reference, they have given beautiful diagrams. So I recommend that you go through them, extrusion versus protrusion, and use them. In the real world, extrusion versus protrusion on an axial slice is difficult. Usually, you will take help of the sagittals. Now, a disc extrusion can be with superior migration. So this is superior migration, and then is this one with sequestration. So the disc is, and this sequestrated disc, the term sequestration is used to indicate that the displaced disc material has lost continuity with the parent disc. And sequestrated disk are exam cases, and always remember that. The same concept, beautiful on this diagram, beautifully done, which we have just covered, that this is the pedicle, and this is the disc level, this is the suprapedicle level, this is the pedicle level and infrapedicle. And in the lateral recess, our nerve was being compressed in the lateral recess here, and then it passed like this. So this thing, let's go back and see the case. Now, so we began with the T2 weighted sequence, and the candidate did very well, immediately picked up something. And I was impressed by that, because many people do not, because they haven't got a protocol. And if you see here, just concentrate on the level of the pedicle versus the other levels which I have pointed out. So this is the L4 vertebra, and now posterior to that, here you see something. And when you go to the neural foramen, the neural foramen is obliterated. The key hole appearance, because the fat is obliterated. So immediately something is wrong. On the other side, it is fine. Now, T1 weighted sequence, I could also have started from T1. And here again, the candidate did very well, because he picked up this lesion here. The only thing is that we have this is the lesion, and you can see the fat is obliterated. So once that is done, and the neural foramen is done, so remember that this is the pedicle, this is the left side, and this is the L4 level. And here, this is that classical lateral recess, and where we are, just one second actually. Some of the other, yeah, now you can see the axial. So this is the disc. This is the lateral recess. So remember this concept. This is the pedicle. So this is the lateral recess, and this is the L4 nerve root, which of course goes into the neural foramen, and it is compressing. It was well done to ask for contrast, because just to rule out any neurofibroma or a schwannoma nerve sheath tumor, but there was none. Okay, well done, candidate one. You have done your bit. Well done.
Thank you, sir.
So before I proceed, I think I have got 5-minute announcement. Yeah. So few announcements. We are next week. I'm going to SRT, and I will be there meeting you, those of you who are coming. And I've got 2 sessions there. One is a viva session. I think 2 hours, if I'm not wrong. And second day, we will cover how to report MR brain. So 2 workshops, and see you there on 23rd and 24th. So somebody else is going to teach. Dr. Anik is going to teach. This session will go on, but I will not be teaching next week. One of our faculty members will be teaching. Then in early June, we have got this extensive program coming up. This is at UKIO. This is 10 to 12 June in Liverpool. We have got about 10 or 11 sessions, I believe, because I've got personally 3 sessions here. And so these will be on 3 days. The theme is Pearls for FRCR exam. Pearls for FRCR. So we'll give you the salient points for FRCR. So I'm going to cover on day 1 acute abdomen 1 and 2, then neuroradiology Pearls for FRCR. Dr. Yajor is going to cover rapid reporting, breast imaging. Dr. Noreen Vikesh is going to cover emergency radiology, Alexia, thoracic imaging, and Dr. Chi, Pearls for MSK imaging, cardiac imaging, Pearls for FRCR, Dr. Samavia. So see you in UKIO. So 3 days, we have got about 11 odd sessions there. Then something which I want to people in the Middle East, they will be particularly interested in this one. We have been invited, to do this course. This will be at the Rashid Hospital in Dubai. Rashid Hospital, 31st August, 1st September. Very extensive course. It is just concerning FRCR2B viva. If you see the name, FRCR2B intensive viva preparatory course. And it is designed just for viva, nothing else. And we have got very limited spaces, so I warn you. There is an email there, if you can note down. I'm not involved in this. I'm going there to teach, right? So if you see the email there, dubaifrcr@gmail.com. Email for registration. Very limited places are there. And so the format is that you will get extensive viva practice. You will get mock exam viva practice with a lot of feedbacks. Total 6 vivas, 4-hour duration over 2 days. You will also, the format is that your partner, you will be in small groups, and you can observe your colleagues or your group mates taking the viva. So indirectly, you will get, this is a second way to learn, and you will get to observe about 12 hours, 8-hour duration. So I think don't miss it. It's a very special one, and we are doing a lot of reflection on how to make it more, better for the candidates, and how you can gain more and more. So this is on 31st of August, 1st of September, Dubai Rashid Hospital. And email this email address to book a seat. And I warn you, very few seats are there. I don't know exactly how many, but first come, first serve. Okay, so that was announcement. We go to case 4. Candidate 2, are you with us?
Yes, doctor.
Okay, just 1 second, please. So this patient has presented with, can you see my screen? Yeah, you can see my screen. So this patient has presented with trigeminal neuralgia on left side, right? And
Yeah.
uh, scan was done. So because of time factor, I'm going to scroll this sequence for you. Just keep looking at it. This is
Mm.
which sequence is this?
This is a flare sequence.
Leading question, do you see anything?
Uh, we scroll again, doctor, to the base?
Yeah.
Uh, yes. Uh, I'm presented by an axial MR examination flare of the head. The images are scrolling from top to bottom. I can see in the uh,
So can I stop you there?
yes,
Basically, there is nothing much on this flare, right?
yeah.
So you did well because you were trying to look at the base of skull. Which sequence would you like to see?
I like to see T2 weighted images or T1 post contrast.
T2 weighted sequence. Over to you.
Yes, doctor.
Now you
This
can take the mouse and scroll, please.
sure, doctor. Request. Okay. This is the T2 weighted MAR images for the same patient. I'll scroll from the button to up, then I'll start to comment the images. Yes. So the thing that caught my eye here, yes, only there is some lag only, doctor.
Yeah.
I need to bring it here. At the level of the here I am in the suprasellar cistern.
Let me scroll for
Yeah,
you
it's
this
better, doctor.
area. So I will keep scrolling for you.
Yes, yes.
I will
Yes,
keep
doctor.
scrolling.
Here in the suprasellar cistern, I am focusing in the circle of Willis. I can see in the left side there is an abnormal large vessel which is present in the left side, which is communicating the anterior circulation to the basilar artery. I think this is a persistent fetal posterior cerebral artery. This artery looks a little bit tortuous and dilated. I can see what appears to me it's like a saccular aneurysm, small saccular aneurysm arising at this artery that I like to confirm in the other sequences
Which
and
sequences will you like to see?
uh, I like to see it if it's available in MRA images, if it's present, and the coronal sequences.
What sequence do you do when a patient presents with trigeminal neuralgia?
Usually, if this patient presenting with trigeminal neuralgia, I'll ask with the T1 post contrast to assess the area of the trigeminal nerve, the cavernous sinus. But here, yes, and
Okay.
yes, this is
What
assess
sequence is
sequence.
this?
This is
Okay. Can you
assess
ask
or
for the
yes,
mouse, please? Can you ask for the mouse?
sure, doctor. Yes. I think the already I have the mouse, doctor.
Yeah,
Yes.
scroll. If you will
So,
not, if you're unable, I'll take over. I'll help you.
yes, I'm scrolling now. I'm trying to focus at the area of the left trigeminal nerve. I'm going up. Yes. Again, I can see this vascular structure, which is coursing in the prepontine cistern. And this vascular structure, it appears to may be exerting some compression in the trigeminal nerve at the Meckel's cave here.
Right. Let me scroll for you. Let me, you leave the mouse.
Sure. Yes. Now this vascular structure is well demonstrated in the Fiesta sequences. Uh, I can see this structure is compressing, exerting compression in the left trigeminal nerve at the level of the Meckel's cave. Trigeminal nerve itself. Uh,
Okay. So how will you confirm this? Now, what is your conclusion and how will you confirm it?
I can see there is a vascular structure arising, communicating the anterior to the posterior circulation, abutting and likely compressing the left trigeminal nerve at the Meckel's cave. I like to confirm this one by T1 by MRI with contrast MRA. I like to
So
see.
we did a CTA. Over to
Yes.
you. Go
Yes.
through it, please. If you can
Okay.
scroll through it.
Okay, doctor. This is the CT carotid and cerebral angiogram.
Just the same region, just concentrate on the same region.
Yes, yes, doctor. Again, this is the same region. I can see the anomalous artery, which is communicating the basilar, passing through the Meckel's cave and extending anteriorly to communicate with the left internal carotid artery.
What is
This
your conclusion, please?
This is anomalous arterial entity of the circle of Willis. I think it's a persistent fetal posterior cerebral artery.
Posterior cerebral artery. Okay, thank you.
Okay.
Thank you very much. Okay, let's go back to the PowerPoint. Case 4. So this is persistent carotid vertebrobasilar anastomosis, and namely this is a persistent trigeminal artery. We'll come back to the name. But overall concept is persistent carotid vertebrobasilar anastomosis. Review of the anatomy. Now, the fifth nerve, the trigeminal nerve, comes out from the pons, goes anteriorly, enters this structure here, which is the Meckel's cave, which is CSF containing. Here is a ganglion, and this ganglion from here, 3 branches, ophthalmic, mandibular, maxillary, and mandibular. The mandibular goes through the foramen ovale, and the maxillary goes through the foramen rotundum. And here, this is the pterygopalatine fossa, just the same repetition here once again. So this is the V1, V2, and V3. Please remember, V1 and V2 pass through the cavernous sinus. So this is with now same, but it has got the meninges over it. And this is that CSF, and this is the cavernous sinus. You can see from here, these two pass into the cavernous sinus. This is the cavernous sinus. And this is the cavernous sinus. And we can see the nerves passing the V1, the V1, V2 passing in the lateral wall of the cavernous sinus and the internal carotid artery also. Now, this is the CIS sequence. Please remember, for trigeminal nerve imaging, you you ask for cis sequence, or this is a physics term, so it might vary in from scanner to scanner, but this is a highly T2 weighted high resolution. Cis is constructive interference in steady state. Now, these sequences are highly T2 weighted sequence. They are very high resolution, thin. So there is no concept of MRA. You will not pick it up on an MRA. You have to ask for a cis. And the basic concept is what we call, this case was slightly different because we could see it on a T2 weighted sequence also. But usually these are small branches, usually of superior cerebellar artery, which aberts and displaces the trigeminal nerve. We call it a neurovascular conflict. I am not going to teach you stuff where what is the sensitivity and specificity of various signs, which I feel is slightly beyond 2B. This case is at the boundary between, is it a 2B case or too specialized? But I selected it for the simple reason that I can teach you anatomy very well on this case. And this is the concept of teaching anatomy using pathology. So, but just to, now what I'm teaching you is slightly beyond 2B. This is neuroradiology stuff, where this is the fifth nerve, and this part of the fifth nerve is known as root entry zone. So when the fifth nerve passes through it, it has got various portions, the root entry zone, prepontine cistern, and then the Meckel's cave. You will see if a vessel is seen indenting and displacing this part, then more chances of it being symptomatic, but not here and not here. Please also remember, when we do a cis sequence for trigeminal neuralgia, other than axials, we do oblique sagittals. That is a must. Oblique sagittals are done along the long axis of the nerve, along this long axis of the nerve. But I don't think so anybody is going to ask you all of this in your 2B. So persistent keratovertebral anastomosis. What is this is from Radiopedia. I've just cut and paste here, but I'll just read what is relevant. The persistent carotid vertebrobasilar anastomosis are variant anatomical arterial communications between the anterior and posterior circulations due to abnormal embryological development of the vertebrobasilar system. And so I don't want to go into all of this. You can read it for your interest if you want. But the most common out of this is persistent trigeminal artery. And our case was this. Arises from the proximal cavernous internal carotid artery, most common persistent keratovertebral anastomosis. And is the most common type of the 4 persistent anastomosis, seen in 0.5 to 0.6% of cerebral, and usually is unilateral. Again, from Radiopedia, this is the diagram, persistent trigeminal, this is what our case was, persistent trigeminal artery. So our case, let me stop share and go back to the case. So candidate, you did very, very well. I was very impressed. Well done. Now, basically, the only thing you got wrong was the name of the artery. Otherwise, you were spot on with everything. This was not visible on the flare sequence, right? And another thing is that your concept, you were asking for T1 with contrast. You were asking for MRA. You are never going to see it like this. You have to ask for this, high resolution T2 weighted sequence. Now, if you see here on this T2, the beauty of this is that on the T2, you can see it. This is the basilar artery and something is going anteriorly. And if you stretch your imagination, this is the trigeminal nerve. So this is a usual sequence. And then you ask for a cis sequence. So this is the cis sequence. And you can see that from the pons, the fifth nerve goes anteriorly. So let's see the normal side. It goes anteriorly. This is the Meckel's cave. and then you lose it. The ganglion, etc., is not usually seen. You can stretch your imagination. This is the carotid artery, so the cavernous sinus is here. Now, on this side, you can see this is it, and there is a vessel which is displacing. You did very well when you were describing it, that I am worried as if it is aneurysmally dilated. I do agree with that. Now, this is the carotid canal, and within the carotid canal, you have got the carotid artery. Here, this is the cavernous portion. And cavernous portion of internal carotid artery is an exam favorite because they will show you cases in which it is blocked. So always it should be part of your protocol to look into this. And there is something happening here. So at this point, it is justified to ask for the next. This case, of course, would be very well seen on an MRA also, but CTA is much better than MRA. And this is the basilar artery. You can see how this artery arises, goes, and then is connected here. So let's trace the carotid artery, internal carotid. So internal carotid, we have gone into the neck. There is a vertical portion as we enter the base of skull. And this is the vertical, and then it becomes horizontal. This is the carotid canal in the temporal bone, and it will pass over the foramen lacerum, and then this is the cavernous portion, and then it will pass through the cavernous sinus, and in this region you can see this connection. So that is what it is. Well done. Now, so this is, are you with us?
Yes, doctor.
This patient is 87-year-old, right-sided butt pain and hip pain, rule out sciatica.
Can I request control, doctor?
Yeah. Have you asked?
Yes, I asked it.
Just one second. Please ask again.
Yes, sure. Okay, I requested.
With you. Over to you.
Okay. I'm presented by a sagittal MRI examination of the lumbosacral spine. This is a mid-sagittal view. I can see that the lumbar lordotic curve is maintained. I can see there is some degenerative disc changes. And I can see as well there is an abnormal high T2 signal intensity affecting the L4, L5 intervertebral disc. I can see also there is some irregularity and some high signal which is present into the vertebral end plate of L4. I'm scrolling now to further delineate what I have seen. This is the exit foramen. I'm going now for the other side.
So what I will do is I will guide you when you go to the parasagittal, which parasagittal are you, right?
Sure.
So
yes. Now I am moving to the left, as I think to the left.
You are going to the left.
Yeah. I can see also there is disc space. I'm sorry, there is intervertebral disc bulge or protrusion. I can see this disc is encroaching in the lower aspect of the neural exit foramen in the left side. I am checking other neural exit foramen, which looks normal. Now I am moving to the right side. I can see the right side, only the disc space is just abutting the inferior aspect of the exiting nerve and the neural exit foramen. I'm worried also about this disc, doctor, because of this abnormal high signal. I'm worried this disc maybe there is some sort of discitis. So I like to review this disc in the T1 weighted images, and if there is a contrast, I like also to see if there is an abnormal enhancement. I'm
Okay,
checking.
leave them out. Leave them
Okay.
out. Okay, you are checking something. Please continue. Continue.
Yes, here in L5, 4, 3, 2, and the L1, I can see there is a partial wedging of the superior end plate of the L1. Also, I'm checking now, I'm focusing in the posterior element of the spine to check if there is any abnormality. I can see there is some facet arthropathy between L5 and S1. The bars interarticularis, I couldn't see any defect within. Now here in this desk space, there is a wedging again, which is redemonstrated. So the main pathology here is the abnormal L4, L5 intervertebral disc showing an abnormal signal along with abnormality affecting the inferior end plate of L4, associated also with a disc bulge encroaching mainly in the left neural exit
Okay,
foramen.
just 1 second, please. I will quickly show you T1. Just don't talk, just see how the T1 is behaving, right? This is a
Yes,
T1, okay?
yes,
So you were worried about this,
yes,
you were worried about this. This is how the T1 is behaving.
yes.
Are you interested?
Yes, doctor. I can see again there is an abnormality in the intervertebral disc of L4.
So
Uh,
you are worried about this thing,
yes, yes,
okay? So now I've given you a stir sequence.
yes. In the stir sequence, I can see there is an abnormal signal affecting the L4, L5 intervertebral disc space, along with the lower vertebral end space of L4, lower vertebral end plate of L4.
So
Uh,
let me stop you. You see, you have got a something which we'll discuss what it is, but can you explain the right-sided symptoms because of this?
Right-sided symptoms. Can I scroll, doctor, to the right side?
Yeah, so let me do it for you.
Sure.
Right now, I am on the left side.
Yes.
So I repeat, I am scrolling on the left side. Okay.
Yes, doctor.
And now I am going to the right
Um,
side.
yes.
Yeah.
Um, now, can I scroll, doctor?
Yeah, please.
Yes. I'm searching also for the cause of the right side pain. Uh, I'm sorry, I didn't focus in the history, so I didn't know the side. I think in my routine practice also, I like to see the axial images.
Okay,
Uh,
just 1 second, please. Just 1 second. Here you are.
yes, doctor.
T2 axial.
Okay. Shall I scroll, doctor, or you will scroll?
So let me scroll for you. So we
Okay.
are coming from L5S1 right
Yes.
now,
Yes. I
and we are going to L4, L5. This is the disk which you were worried about.
yeah.
And then we are going to L3, L4, and
Yes.
then L2, L1,
Yes.
and L1, L2. Now, if you want to scroll, over to you.
Okay, doctor. Now I'll try to focus on the area of interest at the level of L4 5 here. I am
So,
focusing. I'm
so
trying to focus.
let me guide you that I am not interested in that area.
Okay, doctor. So I'll scroll again to check my areas. This is the L5 one. I can see here there's on the right side. I can see there is an abnormal signal here. I'll scroll up to find it out to confirm. Yes, I can see the right psoas muscle is a little bit swollen, showing some abnormal signal here in the right side.
So what
Yes.
what is coming to your mind? What
It's come
you
to
want
my
to see
mind.
next?
It's come to my mind that there may be some psoas muscle infection or evolving POTS disease.
What do you
So
like to see then?
I
Next.
like to see T1 post contrast.
CT.
To see T1 post contrast.
PC. Okay. So I am initially giving you a stir. Over
Okay.
to you.
Okay, doctor. So in the stir images, again, I can see there is an abnormal high signal affecting the right psoas muscle, high T2 signal, which appears swollen as compared to the left one. I'm trying to scroll to check if there is any perivertebral or perivertebral abnormality, but I think I have to scroll to request again. No.
Yeah.
Kindly, doctor, can you scroll for me? Only I need to check the
So
pre.
I am going, just one second. So I'm coming from up.
Yeah.
Going towards the hip.
Uh, I feel that the screen is static. It's not moving. I don't know. This is only for me or for all the audience.
No. Actually, we are not seeing the stir sequence in the images right now.
Okay, let me redo it. Just one second.
Yes, this is the stir. Before I was commenting on the T2, doctor.
Yeah.
Yes, doctor. Now we are scrolling from up down and focusing in the psoas and the iliacus muscle. I can see there is an abnormal signal intensity in the iliopsoas muscle.
What is your conclusion?
My conclusion, I'm suspecting there is an iliopsoas abscess.
And how will
I'd
you
like
confirm that?
I'll confirm that with T1 post-contrast images, doctor.
Okay. And we have got a T1 post contrast, and this is
Yes.
this
Yes.
is it.
This is, I can see there is an abnormal enhancement affecting the right psoas muscle, affecting also the iliacus muscle. I'm checking down if there is any extension to the hip joint or the sacroiliac joint. I can see there is mild, it looks like a reactive effusion in the right hip joint. I can see also the inflammatory changes extend
Okay, that's
along the
fine.
leg.
Thank you. Thank you very much. Thank you. So this case is a simple case. It is again in the category of satisfaction of search. The point is that if you are going in the wrong directions, examiner will guide you. They are not interested here or there. Now, the key thing here was the stir sequence. So first of all, what is this? This is simply intravertebral disc herniations, and intravertebral disc herniations can be with edema also at times. So that is known as an Schmurl's node. But the intervertebral disc, this is the disc. If you are worried about it, fine, I'll take it. I'll not say that you're worried that I want to do a post contrast. It's fine. But then I was not interested, right, as an examiner. Now, the key thing is your satisfaction of search. This is the stir. Actually, I would have given you the stir, and I would have stayed with the stir with you, nothing else. And I would have checked the protocol which you do, satisfaction of search. Parasagittals are critical. It's not just sagittal, because This compression fracture here, there is no edema, so it is not active, right? Now, this is the psoas muscle here.
Yeah.
And once you go to the other side, your psoas
Yeah.
gives signal. It's a definite finding. Agreed?
Yeah, agreed. Yes.
Yeah. So why I have selected this case is just because of this. Satisfaction of search on each sequence. Once you pick it up, then you go to the T2. Now on T2, it's a subtle finding, but a definite finding. And T2 is not a very, very good sequence to pick it up because it's not fat saturated. But having said that, if you compare this with this, definitely there is something wrong. And then, of course, it was confirmed on the stir sequence, and of course it was then, yeah. Now here a bit of fine touch. So it showed enhancement. There was no abscess on the post contrast. But one fine touch is that if you see here, as we go here, these are the adductor muscles. And at this site, the problem is that
Doctor, sorry, we cannot see that you on post contrast.
Oh my God, this is sorry, I think we are having a lot of problems, but now you can see it.
Yes, sure.
So this was a stir sequence, and on this there was edema, this is the iliacus. Remember that it goes to the lesser trochanter. So here it goes. So, and then on this sequence, these are the adductors, and these adductors are sort of here inserting into the pubic symphysis, a bit of reactive edema there. Yeah. It is a simple case. It is a case what we call satisfaction of search. You did well. Well done.
Thank you.
So some or the other, you are in the spine world. So this is your luck. Another spine for you. This is 52-year-old neck pain.
Okay, doctor. Shall I request right?
Yeah.
Okay, doctor.
So the last case diagnosis was infection. It was a ilio-psoas infective process. Right now, there was no abscess, but there was myositis, infective myositis. That was infection. And there was no discitis with it.
Okay.
Over to you. Yeah, this one.
Yes, I'm presented by a sagittal MR examination of the cervical spine. I am available of the mid-sagittal. I am focusing in the craniocervical junction, which looks normal. There is some degenerative disc disease. I'm trying to scroll. Yes, I'm sorry, there is some lag. There is no tonsillar herniation. Yes. Now I am in the parasagittal view. I need to go to the far lateral.
Excellent. I love it because you are applying your protocol now. Very good.
Okay. Now I'm scrolling to the other side. I'm focusing now in the craniocervical junction, which looks normal. Atlantoaxial articulations, I couldn't see any obvious abnormality. I'm suspecting some abnormality here in the clivus that I like to confirm in the other sequences, but
Just one second. Just one second. Don't use the mouse now.
Okay.
I've given you a T1. Over to you.
Yes. So this is T1 weighted images. I'm focusing in the Maro signal. Again, in the clivus, I can see the Maro signal is altered and it looks abnormally of low signal intensity. I am trying to search if there is any destruction. I can see also there is an expansion here. So this is an abnormal T1 signal affecting the clivus. I'm checking the
Is
other.
it only affecting the clivus or something else also?
I'm checking right now, doctor, to check the other bones. Yes, yes, um, yes. I feel that this is a T1. There is diffuse low. I'm thinking it's relatively low. Also, the vertebral marrow signal. But regarding the vertebral marrow signal, I like to confirm in the stir images.
So this is not low, so don't worry about rest of the vertebrae are normal.
Yeah.
What is happening in the clivus, just concentrate on that.
Yes, clivus, I can see there is abnormal expansion of the clivus. There is a predominantly low signal affecting with areas of high signal intensity. The upper extension of the bone I cannot see in the given images. I can see here also this is an extension
What would you like to do next?
I like to see for this cervical spine, cervical MRI. I like to see the T2 weighted images. Then I request also.
T2, excuse me, this was the T2, right?
I'm sorry, doctor. I request MRI brain, and I'll focus in the skull base area.
How will that help you?
I will review more the extension of the clivus. I will see the more the area of the skull base.
Right.
Oh,
So I am showing you a CT, and
yeah,
and this is the journal CT of the patient.
yeah.
Any
Uh,
window you want to see?
bone window. I like to see the bone window, doctor.
One window?
Yeah. So this is the
Over to
bone
you.
window. Yes, bone window of the same patient. I'm focusing in the area of the clivus. I can see there is an abnormal density affecting the clivus. I can see it's expanded. It's showing what appears to me ground glass appearance. I'm checking the other bones. Yes, I can. It's extending also to the sphenoid bone. So this is a diffuse pathology in the form of the ground glass appearance, mainly affecting the skull base. The facial bones looks affected. So the differential diagnosis of this case, it may be fibrous dysplasia. Also, differential may be Paget's disease. Uh, I am worried now. I'm trying to look if there is because this patient may have a
This
nerve
is a
condition.
52-year-old female.
Yes, in this given age, my primary diagnosis will be a Paget's disease. Fibrous dysplasia will be a second possibility because also fibrous dysplasia usually affecting the facial bones rather than the skull base. I like to review the other images for the patient to check if any polystotic disease.
What would you like to see?
If there is a bone scan, I like to see it. If there is an
1 second, please. Just 1 second. There is a bone scan, but it is on PowerPoint. So let me show you the bone scan. This is the bone scan.
yes. This is now I'm presented by whole body bone scan anterior and posterior view for the same patient. I can see that there is an areas of abnormal intense radiotracer uptake at the skull base. Also, I can see there is multiple areas of abnormal uptake along both distal femori, notably in the left side, along also the leg, also in the iliac blade in the right side. Uh, I can see there is normal uptake of both kidneys. There is also, I think it's an physiological uptake in the along the axial skeleton. So this is a confirmed diagnosis of a polystotic Paget's disease. Regarding these findings, areas of abnormal uptake, I like to correlate this with the X-ray of the patient if it's available to check the other features of Paget's disease in the form of bone expansion, cortical thickening, trabeculations. Yes.
You've got an X-ray.
So this is a radiograph of both legs of the same patient. I'm focusing now in the left side. I can see there is an abnormal bone expansion affecting the left leg, left tibia, and fibula. I can see there is multiple areas of sclerosis alternating with another areas of hypodensity. So this may be indicated an areas of activity. I can see also here the radiolucent area may reaching the subarticular surface that may give me non-classical appearance, but may give me an impression of a blade of grass appearance. The same findings, but less evident, I can see in the right side. I'm checking now if there is any pathological fracture, which is I'm not able to see.
What is your conclusion?
My conclusion, this is a case of polystotic Paget's disease. I will refer this case. This case usually, mostly it's already diagnosed. I'll discuss the finding with the referring physician, and I will review the available images of the patient. If there is a new concern for the patient, new development of pain, I like to review this area specifically and to compare with the previous images
Okay. That's it. Thank you very much. So I'll come back to the feedback, but the key thing is that your diagnosis is.
Oh, yeah.
So how? And it's a very good thing that you handle it the way you handle it, because my experience is that many people confuse fibrous dysplasia and Paget's and what are the discriminators. I am going to go into a bit of a lecture here, and I am going to fibrous dysplasia is one of the most important exam cases, and there are so much stigmata which can come, and the way the examiners tackle it is so many. So I have got quite a few slides to show you, and this will be classical potpourri. And I'm sure you will learn from this. Maybe if I had time, I should have put Paget's disease with it, but next time maybe I'll tell you more about Paget's disease. Now, the key thing is I recommend that you go to your Chapman and read this one. So it is a fibrous dysplasia, of course, can be polyostotic, monoostotic. In head and neck, chapter 12.22, it is given in, it can be in the facial bones. Key concept which I want you to remember is written here. You see this thing? And face and calvarium involvement, so in 25% of monoostotic. So please remember that monoostotic can involve face. And more than 50% in polyostotic. And there are some syndromes which you should know. They ask in the exam, but I'm not going into details. Maxilla more than mandible, blah, blah, blah. Key thing, if you remember your pathology, from there you can make your radiology. This is my concept. So let me tell you, in fibrous dysplasia, basically think in a long bone. So what happens? Fibrous dysplasia. Within the medullary cavity, there are cysts, right? And with some of them have got blood, there will be a bit of fibrosis also. So fibrous septa will be there. And then there will be, so where is the lesion? The lesion is within the medullary cavity. Remember that. Now, there can be variable degree of secondary ossification. This variable degree, please remember that we say that fibrous dysplasia has got a ground glass matrix, fine. But where you will be put off in your exam is that you forget that there can be other things. variable degree of ossification. If there is a particular type of ossification, you will get fibrous display, what we call ground glass. But there can be lytic spaces, just like cysts. And then there can be sclerosis because the ossification is more dense, and you can the rim particularly will get it. So, point to remember, take home point, ground glass classical, but it can be lytic. There can be sclerosis also. Now, if you take it further, look at this. Ground glass density, but may also be cystic, lucent and sclerotic border. When it is lucent, it is in active phase, right? More active. And then there is what we call pagetoid type, which is mixed lucent and sclerotic. So all of these types can be present. MR is not very specific. And so it can be variable. Cystic space can be high signal, and if it is no cystic space, it can be low signal. And please remember that active phase will take up on nuclear studies. May it be a bone scan, may it be a PET scan. PET scan has come in the exam with fibrous dysplasia. Remember that. Bone scan has come in the exam. So beware of that. And there will be, the uptake will be depending on activity. Now, this pagetoid type of fibrous dysplasia mimics Paget's disease. However, Paget's occur in elderly. Please remember, 52-year-old is not elderly candidate. So 52 is a very young patient, right?
Yeah.
And now another thing is skull vault and base. So vault and you got it right. Actually, you did mention this, but basically, in our case, there were other discriminators. A bit of anatomy of the base of skull. So I just wanted to highlight the anatomy of the clivus. So this is the clivus. Part of the clivus is made up of the sphenoid bone. Part of it is of the occipital. This purple bone is the occipital bone. And so this is the clivus on an axial. Please remember that in a child, there is a synchondrosis here, and don't call it a fracture or something like that. Now, fibrous dysplasia, look at this. Ground glass is glass whose surface has been ground to produce a matte but rough finish. So this is classical ground glass. This is classical ground glass. This is classical ground glass. This is a beautiful case. Look at this case. This is polyostotic fibrous dysplasia. Look at the medullary cavity. Do you see the medullary cavity? Medullary cavity is gone. It's all obliterated, right? But within that, so this is classical ground glass. Here, with that classical ground, there is a bit of lytic spaces. Don't get confused. What is happening here? Completely lytic in the distal phalanx. Don't get confused. It is the same spectrum. It is the same spectrum. So then look at this case. There is a fracture, and there is a what we call rind of orange appearance. There is a fracture here, pathological, and of course this is a child, right? Epiphysis is not on a CT scan. Now, to give you that concept of, part of it is ground glass, part of it is even has got some cysts, etc. And look at the marginal sclerosis. This marginal sclerosis is known as a rind of orange appearance. And this is quite classical for fibrous dysplasia, another case here. And this is a case where it tells you a story. There is a deformity. There is evidence of previous surgery, shepherd crook deformity. But look at the medullary cavity. Medullary cavity is gone. It's all obliterated with this, this ground glass appearance. Polyostotic fibrous dysplasia, something here, and something here. And you have got that, marginal sclerosis. CT of the same patient, and in the center, you have got lytic area and marginal sclerosis. Marginal sclerosis here. Now, look at this, another polyostotic fibrous dysplasia. And you can see whole of the bones. There are patients living in this world who have got more than 75% of their skeleton is fibrous dysplasia. and look at the same pathology happening everywhere. And this is the that case from Royal National Orthopedic Hospital archives. And this is beautiful case where you can see stigmata of fibrous dysplasia, and then you can see the lytic. So don't get put off by this. This can happen. And so this is then in head and neck, maxilla, you remember? So here you are, zygomatic bone or maxilla, whatever. It has got fibrous dysplasia here, fibrous dysplasia in the rib. It is an exam favorite, right? Focal lesion in the rib, it will be in the differential of adult as well as in the child. This is a fibrous dysplasia in a 52-year-old. This is a classical exam case where they will show you either a bone scan or a PET scan with this kind of appearance. And key thing is you have to ask for plain film. Always ask for plain film. I don't have the plain film of this one. And this is also given in your nuclear medicine chapter, 15.2 in your Chapman. And it is given here, fibrous dysplasia and uptake in 20 to 30% polyostotic. This is from literature on SPECT CT. And you can see this. This sign, I think, is known as pirate sign, pirate, as in the, ocean-going pirates. But this is SPECT CT. And then this is a PET from literature. This particular case had what we call breast cancer. So on PET, all of this is actually fibrous dysplasia correlating with other imaging. This is maxillary sinus fibrous dysplasia, complete obliteration of the right maxillary sinus. If you are not sure, if you just see it quickly, you might say that there is opacification. No, it is all fibrous dysplasia. Look at this. This is what it was. The bone is expanded. Then, so this is the same differential where I had started. Now, this is, look at this. This is that pidgetoid type of fibrous dysplasia. And then clivus lesion. So, of course, in clivus lesion in Chapman, it is given there. I basically shown you a clivus lesion. And then it is in the diffuse and multifocal skull base lesions, unifocal skull base lesions. So everywhere fibrous dysplasia is. And this is what you have to remember. This is courtesy of Dr. H.R. Anik, this case. Fibrous dysplasia with malignant transformation. So base of skull, you can see this ground glass, and you can see this osseous, some destructive lesion. If you see the bone window here, you can see that, look at these walls, they are all destroyed. So this was malignant transformation of fibrous dysplasia, which can happen. So the idea on fibrous dysplasia was that this is extremely important. And now let me go back to the feedback. So candidate, you did very well where you picked up the finding. Now, if you look carefully, even here, this is clivus. If you scroll, you can see that this is going into the occipital bone posteriorly. Yes. And on the other side, it is not to that extent. Of course, on a T1 weighted sequence, the same thing was visible. And, as far as now, the next thing was this CT. On this CT, if you look at the anatomy, now these lytic lesions are, you now understand that it can happen normally in fibrous dysplasia. So the occipital bone, this is involved. And part of the clivus is occipital bone. If you look carefully, this is the superior clinoid processes, and they are also involved. Here, the fibrous dysplasia, my viva could have been just anatomy, just anatomy. I could have spent the whole viva on this with you. I would have asked you which bone it is involving. And other than clivus, it goes superiorly, so the superior clinoid processes are involved, which is part of the sphenoid bone. Here, it is going into the petrous apex, which is the temporal bone. And of course, the sphenoid bone, both of them, they are involved, and it is going into, by definition, these are the pterygoids of facial skeleton, right? This is the facial skeleton which is involved. Pterygoid plates are part of the facial skeleton, not of the skull vault or the base of skull. Remember that. So even here, we have got, it is not just the base of skull. Now, so, and then I showed you the bone scan, which because of time factor, I don't want to change to PowerPoint once again. Then you asked for X-rays, which was very well done. But if you look carefully, you see what is happening. The medullary cavity is all obliterated. There is no expansion per se. There is no coarse trabeculae. That Paget. So what happened that in your mind, you made a diagnosis, and then your mind was trying to pick up the findings of that diagnosis. And this happens. This happens. So actually, this is not a Paget's. Paget's is, very coarse expansion, things like that. And 52 years radiologically also, it's not Paget's. So, but it's a good learning case. You did everything very well, except for the diagnosis. And at times, you did not describe the findings because your mind was fixated with Paget's. So you were putting, you were trying to convince yourself that this is Paget's. Okay.
Okay, doctor. Thank you.
Overall, well done.
Thank you, doctor.
Okay, then. Next candidate with us. Candidate 3, isn't it? Candidate 3. Let me make co-host. Candidate 3 with us?
Yes.
Okay, madam. So, just gynae scan for you. This is a 30-year-old, very young patient, chronic pelvic pain and painful periods. Over to you.
Okay, so I'm presented by sagittal MRI pelvis, T2 weighted image of a young lady presented by cyclic pain and painful periods. Just have a minute to look at the study. Okay, the abnormality here is in the uterus. There is loss of the normal junction, normal zonal anatomy of the uterus. It is obliterated by multiple well-defined hypo-intense and intermediate signal intensity lesions in the junctional zone and the myometrium. The endometrial thickness is normal. And actually the cervical canal is also normal. I would like to check these lesions in the axial oblique and check also the adnexia.
Okay, just 1 second, please. Yeah,
okay.
I'll take the mouse from you. So I've given you an axial. Over to you.
Thank you. So this is axial T2 weighted image of the same patient. Okay, what I can see that there is again multiple well-defined lesions. Most of them are of low signal intensity in the myometrium and the junctional zone. Checking the right ovary. Okay, it is normal. However, there is lesion that I'm trying to see if it is continuous with the bowel or just like adnexial lesion. Okay, it is not. Checking the right adnexia, sorry, the left one. It is
I will give
unremarkable as
you
well.
just 1 second, please. I'll give you another sequence, a T2 weighted coronal. This might help you. Just 1 second.
Yeah, thank you.
Coronal with you.
Okay. Checking the coronal. Okay, again, the lesions are mainly in the myometrium and the junctional zone. So giving the patients history of cyclic pain and painful menstruation, I would be concerned of multiple endometrial deposits.
Where are the deposits? Where are the deposits?
It is in the junctional zone. However, the ones in the myometrium would be
okay.
another.
Show me. Just 1 second.
Okay.
Just one second. I'll go back to the sagittal.
Sagittal. Okay.
Yeah, here. Show me where are the deposits.
Okay. Here is the one in the junctional zone, and the rest of the myometrial lesions might be associated fibromas like leiomyomas. Checking the adnexia, no adnexial lesions, so no endometriomas in the ovaries. And usually I'll check if there are any other deposits in the pelvis. However, I can't see any in the scan, like in the rectum, for example. And
would you like to see anything else?
If we have contrast study, like to check the lesions if it's enhancing or not. Ideally, if leiomyomas are not enhancing.
Okay, what is your diagnosis? Give me your conclusion.
So, in conclusion, this is endometriosis, and the lesions in the myometrium is likely to be associated fibromas, leiomyomas.
Okay, we stop here. So very interesting that your diagnosis is correct, but your findings are incorrect. So let me go through it. This is a, do you do MR pelvis? Sorry, gynae pelvis?
No.
In your practice? No. No? Madam?
No, I don't.
Okay, here you are. So let's go through the basics. So the point is that this is the uterus. This is the endometrium. Around the endometrium is this low signal intensity junctional zone. Now, junctional zone is low signal, and rest of the myometrium is high signal. Within the myometrium, we can see these lesion, this lesion, this lesion, this small, these are all fibroids. Now, these are all fibroids. There is an entity, we call it adenomyosis. Adenomyosis is deposits of endometriosis within the junctional zone. For that, what will happen is that the junctional zone will be thickened and there will be punctate high signal intensity foci within the junctional zone. Maximum thickness of junctional zone is up to 13 millimeter. If it is more than that, then you will call it what we call adenomyosis. So it's not just important to see some low signal, you should also see some punctate high signal within that. And if you go to a T1 weighted sequence, you might get some high signal. So there is no adenomyosis in this scan. And there are multiple fibroids. Simple as that. Endocervical canal is normal, the vagina is normal. But outside, there are too many things which are abnormal. Now, if you see here, this is the sigmoid colon, and you can see, for example, here there are plaques of endometriosis which are deposited on the serosal surface of the sigmoid, and they are also deposited on the serosal surface of the uterus, and they are these two structures are adherent. And similar plaques are deposited here. This is the serosal surface. It should have been like this. There is a deposit there. Now, with that, if you see this cystic structure, I think you picked it up and you were trying to convince yourself, is it gut or not? Then you lost interest in it. So this cystic structure, we have to see what it is. You can see here it is dilated, and here it becomes less dilated. So what is it? We will see it. On the other side, there is a small cystic structure with, again, convoluted type of pattern. Then we go to axial sequence. On axial sequence, now the same thing, uterus, this is uterus, these are the fibroid, this is another fibroid. So, but then if we go to the rectum, this is the rectum, and then sigmoid, and look at all of this. Look at all of this. This is all abnormal. Everything is abnormal. These are deposits of endometriosis. With that, look at this structure, which is next to the ovary. And it looks like here you can convince yourself. You see, it becomes a tube shape. This is a dilated fallopian tube. And this structure also is sort of flute shape. Tube shape, I mean to say. And then if you go to corona, this is, I gave you T2 coronal.
Yeah.
This one. Now, this is beautiful because it gives you so much confidence in sort of, now, do you see this? This is sigmoid colon. This is a plaque which is connecting this with the uterus. So this is abnormal. You see this thing? This is abnormal. Yeah. And then look at this connection between the sigmoid and this. This is all endometriosis. And everything is, look from here to here, everything is abnormal. But the key thing here is, look at this tube-like structure. It is dilated. It is a dilated fallopian tube. And this is one end, and this is convoluted structure, which is dilated. On the other side, there is another one, which is small. Now, the key thing is, you have to ask for a T1 weighted to look for any hemorrhage. And here you are. So this one is hematosalpinx. This one is hematosalpinx. All said and done, this is deep pelvic endometriosis with bilateral endometriomas as in hematosalpinx, and there is no adenomyosis. Okay, we go to the next case.
Okay.
This is a neck MR. This patient is 30-year-old neck swelling.
Okay.
Midline neck swelling. Over to you.
Okay. So this is axial MRI of a 30-year-old patient presented by neck pain. This is T2 weighted image with fat suppression. Sorry, no fat suppression. I can see the fat. Yeah.
No, that's a technicality. This is a stir sequence, which is
Okay.
by definition a fat saturated. So physics says that at times at the edges the suppression is not all that good. So that don't get, this is a fat saturated sequence. Over to you.
Okay. Just checking if I can see any abnormality.
So let me point it out to you. Just 1 second.
Okay.
I'll if the mouse, I'll move the mouse. So don't move the mouse.
Okay.
Concentrate here. What is this? Over to you.
Okay. So just anterior to the larynx, I can see that there is a well-defined oval-shaped lesion with mixed signal intensity. It is mainly hyper-intense with loculations inside and well-defined rim, low signal intensity rim. There is extension in the right posterolateral. From the lesion, I would like to check if it is connected to any of the neck structure.
Can you scroll?
Yeah, let me. Yeah, I can. Sorry.
Just 1 second. Let me, the window has gone. Here you are. Over to you.
Yeah, thank you. Okay, it is extending from the larynx, anterior to the larynx to the anterior part of the trachea. There is like fat plane between the two structures, and no communication between them. It is also likely to be in the subcutaneous fat. So I would like to check this structure in the T1 image.
1 second, please. Just 1 second.
Thank you.
T1 with you. So
Okay.
this is the lesion here. Because of time factor, I am scrolling it for you.
Okay, it is mainly of signal intensity similar to the muscles with foci of high signal intensity, suggestive either of proteinaceous material or blood or hemorrhage, I mean, inside.
So what is your conclusion, or do you want to see something else?
If there is contrast,
Contrast.
fat suppression, yeah.
With contrast here.
Okay, so fat saturated contrast, it is of homogeneous contrast enhancement.
One hint.
Sorry?
I am going to give you a hint.
Okay.
Now, I'm going back to the T2 weighted sequence, which is the stir sequence. This is the lesion. And what is here?
It is
Okay, so give me the diagnosis. The bell is rung.
okay. Mixed signal intensity lesion could
Madam, the
be
diagnosis. Give me the
dermoid.
dermoid. Okay. We'll come back to this.
Okay.
This was the last case, deep pelvic endometriosis. This is case 8, goiter with lingual thyroid nodule. Now, concept about the thyroid gland is that embryologically speaking, thyroid gland actually develops from the floor of the tongue, and there is a duct there which takes it all the way to where it is ultimately embryologically speaking. Two type of things which are very important clinically, and both of them are very important for your 2B exam. One is thyroglossal duct. So this thyroglossal duct usually obliterates, but sometimes it does not obliterate, and later in the life, it might become dilated, it might become infected. So we call it a thyroglossal duct cyst. Key thing is anatomy. It will pass through the developing hyoid bone, either anterior or through or posterior to it. Then slightly inferior to the hyoid, it becomes parasagittal. It will be within the strap muscles, which are right and left. And then ultimately it extends to the pyramidal lobe of the thyroid. Now, other than this concept is the concept of what we call ectopic thyroid. So with this kind of embryology, thyroid tissue can be left anywhere in this path. There are patients in which the only viable thyroid will be sitting like this at the base of the tongue. We call it the lingual thyroid. And it is an absolute blunder to remove them, because then this might be the only viable tissue. So always remember that. And then you remember that when there is thyroid tissue at abnormal location, first of all, to diagnose it. Second thing is, the same tissue can produce pathologies. Two pathologies you have to remember. One is carcinoma. So thyroid carcinoma developing here, number one. Number two is what I showed you, which is a goiter. So we'll come back to the case itself, but this is what we call lingual thyroid. Look at the density here on a CT scan. This is a case from my collection, which was 28-year-old, and neck swelling was there. And on ultrasound, we were all confused what it is. Then we did a CT scan, a correction, and MR. And on MR, you can see that this is thyroid. And then look at the signal. This is that, the same tissue is going all the way up. And this is all same signal intensity. On a CT, it will be same density like the parent thyroid. Here it is same intensity on this stir sequence and T1 and post contrast. So coming back with this to the case, when we do a neck MR, we do a stir sequence, which is an fat saturated axial. We do a T1 non-fat saturated, this is a non-fat saturated axial. We do a T1 pre-contrast T1 weighted sequence, which will be fat saturated, and then post-contrast. So 4 axial sequences. Now, coming back to the first sequence, which I showed you, was this one. Now, if you see here, anatomy is the key. Now, I would have, in the exam, I would have asked you to diagnose it just on this sequence. Anatomy is the key. What is the anatomy? So this is the tongue, and this is the hyoid bone. Just inferior to the hyoid bone, look here. The tissue starts coming to the view. And look at the appearance of it, and it is slightly parasagittal. It has got multiple small nodules. It looks benign, but it has got a peculiar type of configuration. And then it is sitting in the strap muscles. And of course, it is anterior to the larynx. Then it finishes. But the key thing is what's happening to the thyroid. Now, in the thyroid, similar nodules are there. That's the key finding. So similar nodules are there. So this is goiter at the ectopic thyroid, in the lingual thyroid. That is what the case was. And this has come in the exam, and beware of malignancy also at this site. Okay,
Okay, thank you.
Madam, I will scroll it for you. I am slightly pushed because of time.
Okay.
So this case is an interesting case. I will tell you how it happened. This is a 54-year-old. 54-year-old, and this was an outpatient scan. And on this outpatient scan, patient has got leg paresthesia, which is irrelevant for you. Don't worry about it because they had done an MR also. But paresthesia of left side of of face. So that was the history. Now, with that, if you see here, this is which sequence it is?
This is a flare.
Clear sequence. The only finding is this one. What do you think? How will you describe this finding?
This is left cerebellopontine angle lesion of high signal intensity. I can't see mass effect, so the other side looks patent or looks normal of low signal intensity. So my differential for this could be a neurogenic tumor from the
Neurogenic tumor. You know,
like from the
this is sitting within the parenchyma, right? It is not outside. But
yeah.
what sequence would you like to see other than this?
I would like to see the T2 and if we've done contrast scan.
How will the contrast help you?
Just to see if it is purely solid or there is like diffusion as well. Diffusion at DC will help.
This is the diffusion.
Okay, so the diffusion, it is restricted. However, I will confirm that in ADC.
So ADC is black.
So it is restricted. So high T2 high signal in flare and restricted diffusion. It is intraaxial lesion. If it is extraaxial, I would be concerning of epidermoid. Is this patient known to have any? It is asymptomatic patient, correct? Except for paresthesia.
Yeah.
Okay. Yeah.
So give me your diagnosis then.
It doesn't look like extraaxial, intraaxial
Okay, look at the
cerebral.
basilar artery. Do you see anything in the basilar artery?
Basilar artery. Okay, the proximal part is of intermediate signal intensity. It is not the normal signal void. Yeah, here.
So what is your conclusion?
Infarction. Left pontine infarction.
Okay, fine. I'll take over. Thank you.
Thank you.
So this case is a very interesting case as far as the clinical presentation is concerned. It was an outpatient type of scan. weekend type of scan given appointment, and on that, the finding is that on the flare sequence, we pick up this high signal at the middle cerebral peduncle level. Now, on uh, on DWI, it shows restricted diffusion, and on ADC, it is low signal. So it is a classical infarction. Now, this territory, of course, is the posterior circulation. Interestingly, on this, there is stigmata of something happening. Now, if you look carefully, look at this vertebral artery. It is prominent, doesn't mean anything because one vertebral can be, normally more prominent than the other. But if you look carefully, something is happening inside it. And then as we go, as it makes the basilar artery, here there is a flow void, right? And then when it divides into the PCAs, there is a flow void. If I trace it backwards, here you are. You see at least a partial loss of flow void. So interestingly, there is a possible thrombus sitting there, which is very interesting on a T2 weighted sequence. And how do you see it? Because the normal flow void in this region is lost. So, candidate, what kind of investigation will you do next? What will you do?
Contrast scan, like angiogram.
Right. So what we did was that we immediately called, and this was a weekend, and we called the stroke team of the hospital. And this is the classical scenario which they will ask in your exam. What will you do? You have to be very proactive. This was an outpatient scan. And we warned the stroke team. They called the patient from home. The patient was somewhere enjoying with children. They said, no, come immediately. And actually he came on an ambulance. And then we did a CTA. And on the CTA, we can see the same thing here, that just the relevant bit I am showing you. So
Yeah.
this is a bit of calcification in this region. And if I change the window, sorry, this one, there is a bit of calcification, and you can see here it becomes normal. Here it becomes normal. So there is, partial loss of flow. Maybe some flow is still there. So he was actually sitting on a volcano, should I say. But he was saved because he was then thrombolized. He was inpatient for a while and did very well. So this was an interesting scan, clinically speaking. Okay, madam, thank you. Your one, two, yeah,
Thank
yes,
you.
your three cases are done. Okay, thank you. Candidate 4, are you with us? Let me check candidate 4. Yes, candidate 4 is with us. Candidate 4?
Yes, sir.
Okay, so you have got a scan, acute abdomen actually. My favorite. Acute abdomen is my favorite. This is a 38-year-old female, left iliac fossa pain, vomiting, and they have said rule out diverticulitis, rule out PID. This is what the clinical is. Over to you, please.
Okay.
Mouse is with you.
Thank you. Could you scroll for me, please? Because I have a
Okay.
problem.
Yeah. So I will scroll for you just to give you an overview that the upper abdomen is not area of interest and it is normal, right? So we are going left iliac fossa. So now you start concentrating. I will go down, I'll come up, then you start talking.
Okay, this is contrast abdomen and pelvis. CT contrast abdomen and pelvis in a venous phase. There is mild pelvic collection, and the uterus is bulky. The left adnexa also is bulky. I am just concerned. I am just of concern if there is an ovarian torsion.
What
The
will you do
sigmoid,
next? What will you do next?
I will do ultrasound
Ultrasound.
or MR with contrast.
Okay, just 1 second, please.
So this is MR with contrast.
Is it with contrast?
No, this is T2. This is T2 MRI in sagittal plane. There is a large oval shape lesion seen in the Douglas pouch with the peripheral follicles and swirling seen around. I am just, this is confirmation of the ovarian torsion on the left side. I will urgently pick up the phone and inform the gynecologist immediately.
So is it confirmed on this? You want to confirm, see another sequence also?
It's okay to see the fat set contrast. So this is fat set post contrast. There is a collection seen, but the left ovary is not enhancing.
So what does that mean?
That means this is a torsion.
Right, good, well done. So this was a ovarian torsion. Let me go through the scan. Now, the key finding here is that on this CT scan, this is uterus with fibroid, etc. Then there are, ill-defined cystic spaces, etc. So, by the way, there is no role of ultrasound. You should not ask for an ultrasound here. It's a total emergency. So nobody does ultrasound for these. So remember that. Now, on this T2 weighted sequence, what we can see is that this is the uterus, and we can see this lesion here. Now, this lesion is interesting because we can see the vascular pedicle here, and we can see how it is sort of twisting on itself, swell sign. And then this is a distended ovary with some peripheral cyst and a lot of edema in the center. So quite classical for torsion. And of course, there are other signs of torsion. For example, the uterus can be twisted towards it and things like that, which is not seen here. This was the axial. And on axial, just develop your eyes for this edema. From here to here, this is all edema. So this is that vascular pedicle, which is twisted. And that is why there is torsion. And maybe we should see coronal if there is one. Let me see. I think this is a coronal. No. So this is the coronal. And on this coronal, so this is the fundus of the uterus. As we go, now look at this. This is the right ovary. This is the left ovary. See how large it is. And this edema, you have to develop your eyes for this edema. and there is some peripheral cyst. And you can, the sagittal actually showed you the twist much better than any other sequence, but you can actually see that twist here also. But pathognomic with contrast, it does not enhance. Oh, by the way, I forgot that there can be hemorrhage inside. And in this case, there was hemorrhage, which is present here but that is part of the pathology. And on post-contrast, it will not enhance. Okay, now this case is, so what happened was, this is a 70-year-old female. It was an accident in an escalator. It was a metal escalator. She had a fall and she actually come down, many stairs down. So she was brought to the hospital. There was not very significant, on examination injuries, but there was an occipital hematoma. And she had pains and aches everywhere. We did a CT of the whole body. This was a CT of the whole body. Rest of the body was fine. But of course, brain part, they were particularly worried because there was an occipital hematoma, clinically speaking. So over to you.
I'm just scrolling from down to up. Okay, this is the CT brain of the 70-year-old female with occipital hematoma, suspected occipital hematoma. The abnormality is seen on the posterior on the right posterior parietal region. There is a hyperdensity seen over the cortex with no surrounding edema. The ventricles are okay. They are not dilated. I couldn't notice any other hematoma outside, so the differential may be intracerebral hematoma or contusion. However, there is no edema around, so it's not usual. So I would recommend MR with contrast for this case.
So what are you suspicious for?
I'm suspicious of hemorrhagic metastasis or underlying mass. However, the sinuses are okay. I didn't this sagittal sinus and the sigmoid sinus, they are patent. Okay.
Yeah, over to you. MR.
Okay. This is MRI in axial plane flare sequence. I'd like this to. Yeah, this lesion is cortical, is intraaxial cortical, and it's of low signal in the centers and surrounding mild or subtle brain edema. There is no significant mass effect. I couldn't visualize any other lesion seen. I would like to see it on T1, T2, and T1 post-contrast.
So this is the lesion on T2. I'm showing you the T2.
Yeah, this is the T2. The lesion is also hypointense on T2 in the center with no significant surrounding edema, just subtle. I am just concerned if this is a
T1.
cavernoma. Yeah.
T1.
Yeah, sure. The T1 is relatively iso-intense, hypo to iso-intense to the brain cortex. I need contrast, please. Yeah, it's avidly enhancing lesion, which appears. So, from this location, I'm just concerned if it's intra or extraaxial, because this pattern of enhancement without significant edema may be suggestive. Maybe this is an extraaxial meningioma or something like that. I can't see the underlying cortex is splayed or buckled below it, but I couldn't notice any meningeal, any dural tail to call it a meningioma. However, from this sequence, I think it's an extraaxial lesion, and from the CT with hyperintensity, I think this is a meningioma. I just like to review the T2 to see if it's truly extra axial and to see the bone cortex on CT if there is overlying hyperosteosis, which is
Okay, fine. Thank you. Thank you. So this case was incidental meningioma, which had internal calcification. Meningiomas can be high density, and so this one actually had calcification inside. So this is and it was confusing because of the history. You did well where you did ask, if you see here, if I change the window, there is a absolute sure shot type of calcification here. So that is a big giveaway. So otherwise you did well where you said that this is high density. So I am worried about, now I want to correct you there about something. You use the word intracerebral hematoma versus contusion. In a case of trauma, the concept of contusion is when the cortex is involved, when the surface of the brain is involved, you call it a contusion. That is not an intracerebral hematoma. Don't use that word in the context of peripherally based hematoma in trauma. And but you did well that there is no surrounding edema. The only thing, the key thing was windowing, and this calcification, rest of the lesion was slightly more what we call atypical, but there was a definite calcification there. So that was the key. So there was no hyperostosis or anything, but that calcification was a giveaway. Otherwise, you did well. Basically, that calcification, if you saw a flare sequence, which was not very helpful. Now on T2 weighted sequence, this is the T2 weighted, sorry, this is the T2. On T2, of course, just on an axial, it becomes very difficult to comment if it is intraaxial or extraaxial. But at places one can see a bit of a cleft there, but just on axial, it will always be very difficult. Now, you did ask for a T1, which was fine. This is the T1. I had not shown you a SWI. If I have got an SWI, I will show you. This is the SWI. And you can see a bit of calcification inside, which is low signal. And then on post-contrast, it was confirmed to be a meningioma, which was dural based. You did well because I would have given you more sequences, sagittal and coronal, etc. So it is dural based and there is a bit of calcification inside. Fine, you did well there. Last case of the day. This patient is a 41-year-old swelling, pain, right hand. Over to you.
I am presented with the right hand frontal view of the female patient, adult patient, complaining of pain. The salient abnormality, there is endo periosteal resorption on the more marked or more pronounced on the little finger in the proximal and middle phalanx of the little finger, which is seen on the radial aspect of the bone.
What are you picking up? I think you were slightly distracted because of maybe the way it is projecting for you. You are talking about subperiosteal bone resorption, correct?
Yes.
So let me correct you. No, don't worry about that.
Okay. So this is a frontal X-ray of the hand. There is I will check I am just concerned if there is less like better of the distal phalanx of the little and ring fingers. The joints are,
Don't worry about ring finger and that little
okay.
finger. Don't worry.
The middle, the metacarbopharyngeal joints of the ring finger, it's seen, and it's not the joint. It's not seen very well, and there is a soft tissue swelling around it. I'm just concerned if this is dislocation or if there is an underlying mass. I think there is also bone remodeling or scalloping of bone of the head of the metacarpal of the middle finger.
Right.
So I will correlate with the other view, if possible, and I will.
So this is the finding which you have picked up, right? And let me see if the other view is helpful.
Yeah,
Maybe
it just confirmed that this is not a dislocation. It's a soft tissue lesion with adjacent bone resorption. I will recommend MR with contrast for this patient.
So what is your differential here?
My differential may be giant cell tumor of the tendon sheath.
Giant cell tumor of the tendon sheath. So this patient has got pain and swelling.
Septic arthritis, but the joint is okay.
Joint is okay.
Yeah. I think on the other view, the joint is smooth. On the oblique view.
What about the joint space?
It's not. It's narrowed here. It's completely.
So do you think the joint space is normal or abnormal?
Abnormal. So I will.
Okay. So I have given you a T1 weighted MR.
Okay, this is T1 coronal image of the MR without FATSAT, without contrast. There is abnormal marrow signal of the metacarbopharyngeal joints of the middle finger, including the proximal and distal juxta-articular surface, more pronounced on the head of the third metacarpal joint. There is adjacent soft tissue edema and swelling with.
Now given you a stir sequence.
Yeah, there is erosion and periosteal reactions, also adjacent soft tissue edema, which is high on the, but I didn't see a localized. I'd like to review the contrast study to see if there is an abscess or is just a septic arthritis with adjacent inflammation.
Right. That's fine. Thank you. I'll just show you 2 or 3 things and then I'll give you a feedback on this case. And then that was end of the day actually. So this was a case of septic arthritis and you did well. There were just a small few points which I will highlight. Now, this is a case of just a few teaching points. This was a case of osteomyelitis, Brody's abscess. You know, there is a lytic lesion here. There is periosteal reaction here. On MR, I just wanted to show you MR sequences. When we do for osteomyelitis, we must do T1 stir, T1 fat saturated pre and T1 fat saturated post contrast. So this is a T1 and this is a stir. This is a T1 fat saturated pre. This is a T1 fat saturated post contrast. Now, key thing is that the marrow edema will be low in signal on T1 and high on the stir sequence. It should be lower than the adjacent muscles. And if you are talking about spine, then it should be lower than the intervertebral disc. So in this case, there is an abscess here and with a lot of edema. Now, this sign is known as penumbra sign, and this is an exam sign. Develop your eyes on this. On a T1 weighted sequence, an abscess will have high signal on T1 weighted sequence. You know, the periphery will have a high signal. Penumbra sign is an exam sign. When you give contrast, it enhances. And there is a breach of cortex, and you can see intraosseous abscess, and there is a bit of phlegmon, and there is a breach of cortex. So this is one case. Now, this is that another case with penumbra sign, where you can see this high signal on T1 weighted sequence in the periphery. It is considered quite pathognomic of osteomyelitis or intraosseous abscess just on a T1 weighted sequence. This is similar to the case which we had, and this is a case of Brody's abscess. This is a case of septic arthritis where there is on a plain film, there is gas cavity here. This was a case of known case of paraplegia with sacral sore, and now you can see bony destruction here. You can see this gas in the joint cavity, and the head is completely eaten up. And on MR, this is a T1 weighted sequence, stir sequence, T1 pre-contrast. Correction, these both of them are post-contrast sequences. This is a T1 pre. You can see this gas, which is low signal, and then you can see enhancement, and of course, the gas does not enhance. Now, here, now you did well when you described this, but one finding which I think you got confused there, where you initially said about this joint and then you said that this joint is normal. This joint is not at all normal. When there is a joint abnormality, look at the joint space, and the joint space is obliterated. Joint space is when, even in rheumatoid arthritis and other arthropathies, the joint space is the key thing. When the joint space is abnormal, it means abnormal. You did very well where you picked up as if something is happening there, and there was a swelling there. Interestingly, this is a case of human bite. Very interesting. Human bite, you know what is the mechanism? Punch. This guy had a fight 2 weeks ago or something, punched somebody and punched in the face. And I think that is the human bite element. Later on, it became infected. So initially, when he came to the hospital, he was reluctant to tell this part of history because there might have been some legalities around it. But this is what it is. It ultimately at this stage, there is swelling, there is loss of joint space. On this T1 weighted sequence, you can see marrow edema, which is low signal. And you know this is all abnormal. On a stir sequence, we can see that there is a lot of edema. You did very well where you asked for post contrast, which some or the other is not uploaded here, but we did post contrast also. This thing, you were absolutely right. This thing here is in the joint space, and this did not enhance on the post contrast, which is not uploaded here. So this was septic arthritis with, of course, osteomyelitis. So overall, well done. Another thing which I want to correct you is you said about frontal view of the hand. Please remember that there is no concept of a frontal view of the hand or wrist. It is always a dorsal view. So it's not frontal. and it is always a PA of the hand. There was one view which we used to do 30 years ago, which is known as a ball catcher's view for rheumatoid arthritis. Just like somebody sitting in the, in the slips in a cricket field. That is known as a ball catcher's view, where it is an AP view of the hands. That is obsolete now. So always remember it's a DP,
Yeah.
postero-anterior. So that is it. You did very well. Well done. So
Thank you.
now, so quite a long session, but I think it is a very challenging to teach as well as to showcases. So just to highlight this course, which is coming to the Middle East, those of you who are from Middle East, don't miss it. I'm recommending it to you. This is the email, dubaifrcr@gmail.com. This is the date. It will be in the main hospital in Dubai, which is the Rashid Hospital. 31st to this, concentrating on viva, and nothing else. So you will get a lot of practices. You will get, as I've told you, 6 mock exam vivas with a lot of feedbacks, 4 hours overall, 2 days. You will also be able to listen to your group members, which is also very helpful, because when they get the feedback, you get a lot out of it. So, and there are very limited places because of the time factor. We can only invite few candidates to attend it. So don't wait. This is, I warn you, that these seats will go. So that is it. Anything else? Anything else, chat? So if there is any question, 1 or 2 I can take, not more than that. We are already in the close to 3 hours now. If you ask me, but we did ask you people, and you want it, so I'm continuing with it. It's quite a task to do a bit of teaching as well as to do a viva. But I think the yield of this is for learning purpose is very good. Dubai course, any? Oh, no, not at all. That is the concept. It's 1-to-1 course. Somebody is asking, is this Dubai course online? Not at all. It's 1-to-1. You will be sitting with the examiner. 1-to-1 is a different concept, and so this will not be online. That is the answer. So about SRT, somebody is asking if SRT is online. I have no idea. You can ask the organizers if anything is online or not. The workshops might not be online, by the way. My sessions are workshops, right?